Good morning, my darling, I'm telling you this to let you know that I'm sorry you're sick. Though tears of sorrow won't do you no good, I'd be your doctor if only I could. What do you want from the liquor store? Something sour or something sweet? I'll buy you all that your belly can hold. You can be sure you won't suffer no more. I'd swim the ocean or the deepest canal to get to you, darling, just to make you well. There's no place on earth I would have hastened to go to cool the fever. This I want you to know.
Hey, I'm here with Tim Faust. Thank you so much for joining us on Taproot Therapy Collective's Discover, Heal, Grow practice, or their Discover, Heal, Grow podcast. And we're going to talk about some of the effects of Medicaid, how that system works. So you have, kind of arcane knowledge of the secrets of Medicaid. Could you give us a little bit of your history and share some of that with us?
Sure. They make these things too complicated. My name is Timothy Faust. I'm a healthcare writer. I write some articles. I write some policy. I wrote a book. For a lot of the past 7 years, I've been traveling around the U.S. talking to folks about healthcare and how health policy shapes things in their backyard, right? Healthcare policy is pretty localized, right? What healthcare needs looks like in Birmingham and Milwaukee, where I live, we've got different kinds of needs, different kinds of factors. And healthcare needs in Milwaukee and northern Wisconsin are different, different kinds of circumstances, economic forces, environmental factors. And so getting an idea of what healthcare looks like on the ground or place to place has been really wonderful, and I've gotten a chance to learn a lot about healthcare all over the country.
So, like, a lot of your writing is about taking kind of like obscure and sometimes like absurd policy and then sort of clarifying like how we got here and like how those things work, or just some of the service gaps and the arbitrary nature of how these things are going. Can you tell us like how you got into starting trying to translate I would say the intentionally obscure healthcare policy of the U.S. into layman's terms? Because it seems like a very good way to democratize kind of information and sort of empower people to understand what legislation means for them. How did you identify that as kind of a niche and go?
In 2013 and 2014, I had a job in Florida enrolling people in the Affordable Care Act in Florida, Georgia, and Texas. And, I didn't know a lot about health policy. I wanted to learn what was going on. And I knew that having insurance was important. I'd been on Medicaid a couple of years prior for an accident. And it was crazy up. So it gave me a chance to not go into five-figure credit card debt. And so I thought, okay, well, I'll get involved in this. Those three gap states chose not to expand Medicaid. So I kept running into people who didn't qualify for ACA credits, like money to give them credits to buy insurance because they didn't make enough money to qualify for subsidies, but made too much money to qualify for Medicaid. And that whole existence of a class of people who are both too poor and too wealthy for help getting health care totally broke my brain. I didn't know how to process that. So I spent the next couple of years doing research, talking to folks. Eventually found that there was use, there was a need for people to talk about healthcare and regular person ways. And I did okay. I can do this. I've got some of the background. I've got some of the information. I like reading a lot. I read a lot about healthcare. So why not go out there and talk to folks about healthcare in language that like normal people can use? Because this thing's it's very complicated for a lot of very silly reasons, right? Like
Yeah.
the way you run healthcare in America is not a way you would design healthcare to be run. If you had any say in the matter, you were designing it from scratch.
You would never just sit down with a protractor and a spreadsheet and say, I want to design a system that works and then end up with anything that looks like what we do today,
Absolutely not. And it's a series of historical accidents and one-off agreements that got entrenched. Policy, fixes, most famously during World War II, there was a wage freeze. And so in order to attract new workers, employers began offering insurance as an employment perk, which had to become like the backbone of how a third of us get our insurance. Things like that. It's a bunch of accidents over time. And as a result, we've got this very messy, very silly, very Byzantine, hard to follow model.
I mean, one of the things that I bump up against, because I'm a social worker, so I was on a assertive community treatment team, working with some of the most seriously mental ill people in the state, and billing Medicaid for that when I first started before we had the complex trauma practice. And like what I find is that a lot of times the people at the top, the politicians or the sort of journalists with a axe to grind or a political agenda, they'll make these arguments that sort of like sound like they make sense, but when you dig into them, and most people just kind of think that that's true, and they're like, "Oh, okay, you cut Medicaid, you save money or something." But when you dig into it, it's like that's what the voter base thinks, that it works that way. But when you talk to those politicians, like they know that it doesn't really. They just know that people are susceptible to certain lines of argument. Like when I was on the assertive community treatment team, we took people who were chronically homeless and had been in and out of the state mental facility for years with no improvement. And Medicaid's like, okay, we'll pay a higher rate for assertive community treatment because these people cost so much money, and they're going to the ER all the time and they're saying, I'm the king of England. And then the ER gives them a sandwich and says, here's a script that you can't afford for a disease you don't understand, with support you don't have and money you don't have to fill the prescription for an antipsychotic. And then they come back the next day or, later that day. And a doctor did a study on that group when I was there. And they were like, do you realize that you've got 13 people, you've got, 3 nurses, you've got a psychiatrist, and you've got, all these social workers, which are pretty cheap. I think I was making like 35,000 a year at that point. And they see about 150 people a year, give or take, 20. And that for every one of those people that this 13-person team is able to see, you save the state Medicaid system $1 million. Right? So it's like, okay, well, this makes sense. The politicians are saying that they want to cut this and all this stuff. Well, like, you're paying me $30,000. I'm giving you 1 million times, 7, 8 people. I'm giving like, if this is about money, this is a pretty clear thing. And yet they would come back and say, no, we need to cut it. We don't want to have this because it's not really about the money. It's about, people assuming that they want the voter base to assume that it's about the money, but really a lot of people just don't want these systems to exist, I think.
Yeah, I mean, I talked to a lot of legislators, and I'd say half of them are doing exactly what you say. And I was using, like buzzwords or marketing language or whatever that they know people might like because it sounds reasonable. Saying half of them, yeah, are straight up ideologues, or even worse, don't know what they're doing, and are firing themselves the taglines that they've been given. The thing with Medicaid and those patients you talked about is that private insurance isn't an option for a lot of these people because they're too expensive to take care of. It's the entire backbone of the way the insurance system in the U.S. works is that healthcare costs a lot of money for a lot of reasons we could talk about. And it's not very profitable to sell insurance to people who need a lot of healthcare. And so the entire point of insurance is we all put money into a big pot, and then part of that pot is used to pay for healthcare for people who need it, because healthcare costs really can vary from year to year for a person, right? Sometimes some years you don't go to the doctor at all, and some years you get hit by a car or, get pneumonia or cancer or something like that, and you need a lot of healthcare, you need a lot of money, but there's no way you could pay the $20,000, $50,000, $100,000 like hospitalization fees on your own. So the idea is we all put in, and when we need it, we take money out. But insurance companies want to make money. And the way they make money is by paying less on care than they receive on premiums. So if you're somebody who is poor and can't put a lot of money in the pot, or you're somebody who has a chronic illness, you've got cancer, you've got a pediatric disorder that happens throughout time, you've got a mental health problem, it's going to cost a lot more pay for your health care, then you'd ever be able to pay for premiums. These people just for a long time didn't get health care. They were excluded from insurance models, right? Now we have a standard saying that, technically you can't be turned down for buying insurance if you have a pre-existing condition. But there's also some other ways to exclude people from getting insurance.
Health screenings, you started to see those after Obamacare.
Right.
A lot of
Or just denying care altogether, right? There's lots of ways to wriggle out of paying for somebody's health care, even if you're, in theory, you can have to pay for it. And so because we don't want these people to be abandoned for a variety of reasons. One, it's very expensive and causes a lot of problems for all of us. Two, I think it's fundamentally unjust to let these companies wriggle out of caring for people. We have programs like Medicaid, which pays for low-income people who are really sick, and Medicare, which covers senior citizens who tends to need a lot more health care than people, under age 50 or whatever. And so we've built these government programs that basically take care of people the private market would never be able to. And, I'd say that there's a lot of people out there still who the private market can't take very good care of, but they're still locked into the system. But it's a way of recognizing that healthcare costs are entirely unaffordable for normal people. Unless unless you got $10 million in the bank, you probably can't pay for your own healthcare. And finding a way to both take care of them, but also invest money into the parts of the country where real differences are made. Like if you live in a rural area, I live in Wisconsin, half of us live in rural areas. It's not profitable to build a hospital in a rural area, right? Because you're not getting, if you build a maternity ward, like a place to deliver kids, you're not getting 10 births a day if you live in a rural area, right? Because there's just not enough people in the area. So hospitals don't want to build facilities in rural areas, or they want to close those facilities and focus their money into wealthier areas or areas with more people, like suburbs.
Which then puts stress on cities like Birmingham when you've got people driving from Mobile to come to UAB. So it's going to affect the city eventually. A lot of the people that are in the city, maybe feel safe from some of these cuts, but it when the system is under strain, when there's service gaps, it affects everybody negatively.
Private slab across the entire board, right? And Medicaid is the one payer, the one insurer in the country that puts most of the money into rural healthcare providers or rural healthcare clinics. About 50% of rural clinics and rural hospitals are, just barely breaking even or even in the red. And Medicaid's the one thing keeping them from closing. We saw in states that didn't expand Medicaid a 4 times higher rate of rural hospital closures than we saw in states that did expand Medicaid. It's like a backbone for how you pay for healthcare in areas where it's not profitable to either offer or pay for healthcare.
Well, and I mean, when you're saying that they can't afford to take care of these people, I mean, I think you mean like private insurance cannot make money off of them. It's not profitable for private insurance. But like a lot of times, I think Medicaid expansion gets framed in kind of lefty language of human rights and that these people have a right to health care. I definitely believe that. But even if you don't, I mean, when you just look at this model as a business, when you are not taking care of certain people in a country that you are tasked with running as a politician, you're going to make things more expensive when you don't take care of some people. I think there's a business case to be made too for like why cutting Medicaid is bad for everybody.
So when people can't afford healthcare, when they're on the hook for costs, they're totally unaffordable to everybody. They just don't get healthcare, right? That's why you've got a huge medical debt problem in the U.S. 1/3 of families have small medical debt. 30% of them have medical debt over $1,000. And people are in debt or when they're afraid of costs. And that goes across the board. We've seen all kinds of people, even higher income people, have medical debt now. They just don't get health care, which means problems get worse and worse and worse. And they fester until all of a sudden, you're dying from stage 4 cancer. You get rushed to the ER and you spend so much money to take care of that person at the end of their life.
Per hospital. And so when they could have had a life, just because preventative care is not funded, we avoid these things or accessible. We avoid these things. And then it is a more expensive problem to treat,
Right. Also, healthcare now saves money down the road. And also, more than that, makes people can have longer and better lives, which is good for all of us, right? Because everybody who's got a family member, 1 in 5 people in Alabama are on Medicaid, about 20.1%. And it's a pretty variable mix. Again, like some years you lose your job, some years you get a job, some years you get hit by a car, some years you don't see a doctor at all. It's like this pretty shifting, pretty amorphous population. I was on Medicaid for a couple of years in California, and then I wasn't on Medicaid a couple of years later in Texas. It's like, our lives can change a lot and look very differently from year to year. And so people kind of float in and out of Medicaid the same way they might float in and out of unemployment or whatever, right? Mm-hmm. And if you happen to be on Medicaid in a given year and you start getting a weird cough, which literally happened to me. I had a weird cough. I ignored it because I had already paid a bunch of money in healthcare bills, and I was afraid of going further into debt. I had to kind of ruin my credit about having to pay down bills on my credit card, but I didn't have insurance. So I couldn't afford to buy it. And I ignored my cough. It got a little bit worse. I ignored it. It got a little bit worse until one day I woke up with a fever of like 103 or 104 degrees. Which was much higher than it's supposed to be. And my roommate rushes me to the ER. They bring me in. I had double pneumonia. I had pneumonia twice, 2 parts of my lungs, which can be like a life-threatening condition if you're not like, for some people. I already have pretty bad asthma, or I had pretty bad asthma at the time, so it was considered a pretty big concern. So they bring me in, they keep me overnight, they pump me full of fluids. And when I leave to like a $5,000 or $10,000 hospital bill, and that would have completely ruined my life. Right, I was working 3 jobs, and I was still making $14,000 a year because it was during the financial crisis. I was working a bunch of minimum wage jobs, and when it all give me, like $40 a week, I was kind of cobbling things together. And fortunately, while I was leaving, a worker at the hospital said, okay, well, you might be eligible for Medicaid. We just expanded Medicaid. Let's do some paperwork. And thank God I was, because all of a sudden that bill dropped to $0. And I was able to have, the only reason I have the life that I have, I've got a wife that I love very much. I've got a little family that I love very much. I've got a dog that I love very much. I can do work that are interesting to me. It's because I wasn't put under the burden of, 5-figure medical debt when I was 23. I was able to do things and take jobs and go places that have made my life, better and richer and more interesting. And I've made my friends' lives even able to have an impact in the lives of other people around me, only because I wasn't thrust under all that debt at a vulnerable point in my life.
And a working person who is part of the economy in a good way. I mean, half the reason some of the brilliant people that I work with in therapy are not going back to school or not kind of pursuing the thing that they're totally interested in and capable of doing is medical debt. I mean, the medical debt is what stops them from accruing the educational debt that they might be able to pay off, with the job that they're definitely qualified to do, but they're stuck in a restaurant or they're stuck driving Uber.
Yeah, absolutely. Medical debt, medical costs are one of the biggest causes of bankruptcy. I think actually the biggest cause of bankruptcy in the U.S.
I mean, how much of your workforce are you losing when you're just taking the smartest people who may not be born with a ton of money, but are totally capable of doing this stuff and not giving them a pathway to go do it?
And you mentioned some of the silly things of Medicaid. So we've gotten such this big, overriding belief that only some people deserve government programs or whatever. So you need to find the exact line of income, $12,800 or whatever, above which people don't receive benefits and below which they do. That means you don't take a promotion. You don't take on more hours. You don't take on more work. I was talking to a guy in upstate Wisconsin who's a cobbler who makes shoes for people who have prosthetic legs. Great job, super important. A job I never thought about existing until I talked to this guy. And he's got multiple sclerosis, so he needs Medicaid to get all of his medications, cover his hospital visits. He's not a working person. He wants to do his job. His job is important. It's very social, helps everybody. But if he takes on too many clients, or if he does too much work, he stops being eligible for Medicaid, which means he would die, because no private insurance will cover all the bills at a cost he can afford to get the health care he needs. So the total rate, so there's a couple of options: work fewer hours or die. And this kind of model where we really limit public health care, public programs to just the poorest of the poor, and most of whom are working. I think 92 to 98% of people who are on Medicaid are working, have jobs, or are in school, or are caregivers full time for somebody at home who has a chronic illness or is old. You really put a cap on their ability to take on more hours or do more kinds of work when you restrict Medicaid to just, the hyper poor or the super low income. It's counterproductive. That's not what you would want to arrange a society if you had the option to do it from scratch.
Well, I mean, in my lifetime, I've wanted to hear somebody advocate the need for broad, universal programs, not just healthcare, but just these are the baseline of what you get as a citizen that pays taxes. And yeah, I mean, I think even more so than the Republicans. I mean, the Democrats in my lifetime, it's like every time these things come up, oh, we're going to do it responsibly. We're going to means test. We're going to meter. We're going to have caps. We're going to make sure that you're somehow eligible. We just can't have public education. We can't have public health care. I mean, can you speak to how it the sort of gaslighting that it sort of feels responsible if we have double, triple means tested filters to stop the wrong person from just being able to get diabetes medication and somehow only get the right people, how that is sort of the self-defeating model of legislation?
Sure. No, this whole notion of deservingness is a really complicated question that we've grappled with different ways over the past couple of 100 years. But at the end of the day, the more obstacles you put in the way of somebody being able to get health care or being able to get other benefit programs, the fewer people who are eligible will get it. Right? I used to, in my day job, I help enroll senior citizens of Medicaid. People who are 65 who are super low income or have a disability. And I am good at applying for Medicaid in a lot of states. I've done it professionally for a long time now. I've got software and I've got phone numbers and stuff. And if you still take somebody 2 or 3 weeks or even longer to apply for Medicaid, because you got to because of the fear that we let somebody in who has too much money or who is on the line and who doesn't actually deserve to get a public program, we put all this paperwork and all these obstacles in the way of getting health care. And if you're a low income person or you're a senior citizen or you've got a disability, getting all of your bank statements, your car payments, your income, your social security check, your social security card, getting all these things together.
Just the absurdity of the application. Like, if you haven't looked at a Medicaid application and you're listening to this, just go look what you have to fill out, to say that you are disabled, or to get SSDI to apply for Medicaid. I mean, it's like you need almost like a team of social workers and a lawyer to apply for some of these programs in some of these states.
And sometimes that's exactly what you need, right? You do have teams of social workers with lawyers who go through this because it's so complicated. You think saying that your taxes is more complicated. Applying for Medicaid 5 times more complicated than filling out a tax form, even on a normal year. They really grow everything in your entire life to make sure you don't make $1 more than the state thinks you should make if you deserve health care. And because of that, lots of senior citizens, lots of low-income people, lots of people with disabilities fall through the gap, not because they don't, not because they're not eligible for the program, because they don't have the ability to go back and forth over and over again to fill out the paperwork. And on top of that, states don't invest money in making the application process smooth. In some states, we don't even have a central database connecting all the cities together.
In 2025, you're tracked by like 15 different ad companies. Like if your toddler clicks on an app, but we don't have a way to centralize, the state's Medicaid system in some of these places.
In some places, you got to apply in person. They don't even have a place you can mail or fax stuff or even do it online. There's a good study. So Georgia is a state that just passed work requirements for Medicaid, which is another level of paperwork. If you're going to be on Medicaid, you got to work 80 hours a month, which again, everybody was already doing. But now the process of getting the form and filling it out and finding the paperwork to certify it and then uploading it or whatever. There was actually in Georgia a couple of years ago. And they had like the spokesperson, this guy he was a mechanic who was like, I work 80 hours, I work more than 80 hours a month. If I can do it, anybody can do it. And over the course of the next year, she lost her insurance 3 times because the computer system broke down or the paperwork didn't get like. The more layers of complexity you build into this, the more ways there are for it to break.
You're looking at, in some states, in my experience, like 3 to 9 months of approval time. It's not like, okay, they didn't get the form, mail it again. It's like you wait 9 months before you find out that the form is missing,
And a great way to solve all these problems is just to expand healthcare to people that need it without having to go through all the rigmarole, right?
A form with 2 questions, are you a U.S. citizen and are you a resident of Alabama?
Mm-hmm. No.
Done.
And that solves a lot of problems. But, we've got, the insurance industry doesn't want to stop existing. They spend a lot of money paying it to politicians, both Democrat and Republican, to show why they're a necessary component. Even though fundamentally, the job of the insurance company isn't just to pay for your healthcare, it's to keep costs down, keep costs manageable. But healthcare costs skyrocket way faster in the U.S. than they do in other countries. And they skyrocket totally unnerved from things like inflation. There's a study of MRI, like MRI is the big tubes you wear and then push a button, scans your body. It said one machine, look at MRI prices in Washington, D.C. And the literal, exact same machine, you can touch it, the same literal machine can have a 5-fold cost variance based upon which insurer is paying for it, which doctor is around, and what day of week it is.
Yeah, hospitals employ an entire billing department of people who just go through and say, well, that same service could kind of be construed as 6 different codes. So your job is to figure out which CPT code is the most expensive one to bill for that sort of meets the criteria for this knee surgery that could be 4 different things. Every healthcare system has that room full of people.
You got this war between hospitals that want to charge as much money as possible and insurers who want to pay as little money as possible. And so there's got, across the country, probably like tens of thousands, if not hundreds of thousands of people whose job it is to litigate every individual line item. And there's a war of who's going to pay for it, how much it costs. And ultimately, at the end of the day, both these companies make more money year over year. And the people who are screwed are people like you and me, the patients who have to pay for the bills at the end of the day, or who get these costs unfairly or unjustly dumped upon them. This whole model does not keep costs down, and it does not provide coverage to everybody. So what's the point? In every other country in the West, every other country that has like a functioning healthcare system, there's some central authority that regulates prices, right? Because left totally unchecked, prices will skyrocket, completely unmoored from the actual
And
cost of
cartels will
Medicare.
form under, things like the AMA and things like that. They will start to operate like cartels. They are a monopoly and they set their own rates, which is not something that most professions can do.
You see that in states right now where rural care is being purchased by all these big hospital systems, which then close care knows it's not profitable and shuffle it all into the suburbs usually. And then because we're the only game in town, they jack up costs. The cost of providing care hasn't changed. A good example is
And doctors aren't making more. Doctors are doing more paperwork and leaving the profession, and we're getting brain drain in healthcare. But it's not like doctors make a lot, but it's not like when the healthcare costs do this, it's not like doctors' salary are doing that. I mean, these things are generally going to enrich people who most Americans do not like and do not want to enrich with the policy decisions that are being made.
And because of the backward way this entire system is arranged, if I'm a doctor in like a regular clinic, in your neighborhood, I charge, let's say, I don't know, $50 to get these shots or whatever. If a hospital acquires me, that exact same service in the exact same building now costs $200 just because the hospital is better at negotiating. The actual price, or because they're a monopoly, right? The actual price of providing the care hasn't changed. But once the hospital acquires me, the costs come out of nowhere and they skyrocket. That's an example of how this whole model works. In every other country, you've got somebody in the middle who says, hang on now, like Medicare can pay $30 for shots, and the provider still makes money, and it's this is the actual cost of care. And we're going to keep your costs at 5% growth a year over this core cost, and then adjust it year over year based upon trends in our healthcare, provided more costs come from. Every single country, even the ones that have market solutions, have this central price setter, and we don't have that in the U.S. We delegated to this distribution of private insurance companies who are both incapable because they're too small and unwilling because they get paid more at the end of the day through higher premiums to bring those costs down. And that's a massive problem in American healthcare. And so a thing like a single payer, a thing like Medicare for all, one, guarantees coverage for all people, but two, it addresses those cost concerns by reallocating the spending that we have to pay for care that's essential, pay a fair price for it, but not get totally extorted by like the gaming, extortion of how prices are set.
Well, like a lot of politicians and a lot of voters claim to, if you really just cared about the cost of healthcare, there's a lot of things that you could bipartisanly do tomorrow. I would say like one of those things is like the bulk buying power. Because insurance companies say, hey, your drug's expensive, we want to cover it, but we're not going to cover it at the money you're charging. So go ahead and give us a break on that. And they use that to negotiate. Medicaid doesn't. Medicaid just walks out. They don't use the bulk buying power of the U.S. government to say we're the biggest healthcare system in the country, and we're going to, 20% of Alabama, we're going to, play hardball with you to get the price of these drugs down. We don't do that. I mean, two, like you've got, like a lot of the way that these drugs are developed, people are like, well, Pfizer can charge $1 million a pill because Pfizer paid to develop this stuff. No, they didn't. Half of these drugs, you took taxpayer money and then you paid a private company to make the drug, and then they own it. And then they get to say what the U.S. taxpayer has to pay to get it. If I pay for something, I want to own it. If I build you a house, I want you to pay me for the house. But, we have a lot of these giveaways to these companies that drive these costs up for everybody for no good reason. I mean, I don't think right, left, anyone who understands that would think that it's a smart system.
And on top of that, a lot of the research that these drugs come from are that unpaid or underpaid grad students at universities who actually do the experimental research, right?
Mm-hmm.
And then the research is packaged and sold by the university to a private company, who then takes those results and uses that to build healthcare. So that's the core experimentation, the core figuring out what's even possible, that's already being done by the public sector. It's just being sold to insurance companies at pennies on the dollar. Then it's turned into a product that's sold back to us at extortion rates. And yeah, if you've got one group, one payer, whether it's Medicare for all or one national insurer or whatever, that's buying the drugs, it can do a lot more to bring costs down. I say, listen, if you're going to sell Wegovy, if you're going to sell insulin, if you're going to sell heart meds or whatever in the US, we're the one guy that buys it. And so we're going to extract a fair price, one that makes sense in the market, but one that makes sense for us, as opposed to having 10,000 different insurers that only insure, 5 to 20,000 people who have way less negotiating power and way less bargaining strength than that larger payer. And that's not having that single group that can represent all that buying power, set costs. That's what they do in other countries, and that's what works for them. And we just don't do it. We're just diffuse model.
Why don't we do it?
Pretty inefficient because there's a lot of money, and that's not doing it that way, right? We spend about $5 trillion a year in healthcare. That number goes up every year, and a huge chunk of that is industry profit, lobbying dollars, and bullshit administrative costs that just create money for administrators and workforces that exist only because of the way the model is arranged. When Medicare, which is insurance for old people, and Medicaid, which is insurance for local people, were proposed in the 60s, the AMA launched a big, massive wall-to-wall campaign saying this is social medicine, going to take over the agency of your doctors, it's disastrous. And they tried that exact same playbook over and over and over again. Sometimes it works, sometimes it doesn't, but with the extension of Medicare and Medicaid, all of a sudden doctors can get paid for seeing a lot more patients than they could before. It was a totally backward argument. But this resistance to having any kind of oversight, any kind of accountability, plus, the millions and millions of dollars they spent on lobbying means there's a pretty high resistance against changing things in those that make sense.
Well, and I've seen, in my lifetime, the reason to cut healthcare, a lot of when Medicaid gets cut, the argument is that you have to. I just want to talk for a minute about how economies work, where money goes. Even if you don't agree with certain kinds of spending, maybe certain kinds of spending that you don't agree with could be more beneficial to you. I was thinking of what is it? Who's the director of Avatar? The James Cameron. Yeah. So James Cameron was, when they were telling him you've committed to build, you've built all this infrastructure in New Zealand to do all this prep work for these Avatar movies. You've got $4 billion or something in making these movies. They're the most expensive movies ever made. What if they don't break even? What if they don't make money? And he was like, what we do with the money when we pay movies? We're paying artists, we're paying designers, we're paying craftspeople. We give it to people who are using it, and it's going back into the economy. So I've got a pretty good track record. I think the movies will make money, but if they don't make money, the money was well spent. And, a lot of times, I've seen the military spending that is a lot of times where the money goes when Medicaid gets cut, go from the 1980s where they're we paid for a bunch of fighter jets that were way over cost and they kind of don't work. And there was all this speculative technology. And then it turned into, we just got to do no bid contracts for these wars, and these military contractors will get to charge whatever they want. And there's no provision for the government to kind of recoup anything if there's waste or abuse. And now it's we have to build metal or solid weapons and lasers that will never work at all. And when you're giving money to those systems as opposed to healthcare, the money goes away. It goes to a hole in the desert where it's lit on fire and it will never really be returned to a local economy. When you're making Medicaid, you're making jobs. You're making skilled jobs in rural places. You're a country, the U.S., that doesn't have a lot of manufacturing. When you fund this stuff, you're putting money back into not just let's give away free healthcare because we want, to do, social justice things, but you're giving it to nurses, to doctors, to techs, to social workers who can be employed to actually, do something beneficial in this country.
The most common job in Wisconsin is home health worker. And those folks are paid entirely out of Medicaid. Wisconsin, where I live, spends $11 billion on Medicaid last year. And that money doesn't get lit on fire and turn the desert. That money is salaries, income, massive economic drivers, right? Every dollar spent on healthcare is a dollar that at some portion goes to a doctor or a nurse or a home health aide or whatever. And it keeps, especially afloat. It is the economic backbone of a lot of parts of the state and a lot of parts of the country. A fact that I read 10 years ago, so maybe it's out of date, is that every dollar spent on healthcare creates $4 of economic activity. So it turns into salaries, which would then spent on other things, and you pay your rent or you buy your food or whatever. Like
You go to
healthcare,
the restaurant that is
right?
closing. You go to the hardware store that is in your town. You have money to keep your house from falling into disrepair. You can hire a carpenter. You can hire a plumber. You can create jobs with the money that is being returned to the local economy.
Right. So every healthcare dollar creates $4 of economic activity, and every dollar spent on defense or military stuff creates less than $1 of economic activity. Like if you were optimizing your spending to make the most money long term, you would put it all in healthcare. Obviously, it's also like it's the thing that keeps a lot of local economies functioning is the fact that you can have in a lot of places, the hospital is the biggest employer in town, both urban and rural areas. Most cities and most cities in the U.S., if they don't have a big university, the hospitals are the largest employers in the city.
Our big hospital is the university. So if you colored out everything that is UAB in downtown Birmingham, you don't have a lot of downtown Birmingham left.
But this money is like you said, that's keeping all these jobs afloat. That's keeping all these people able to pay for stuff. And on top of that, a lot of people that do essential care don't get paid very much by either public or private healthcare. My state, home health workers make less than they would make if they worked at a gas station. It's really important work. I talked to a woman a couple of months ago who is a home health worker for her mother, who's disabled and elderly. And so she wants to do that job. It's very important. She wants to take care of her mother, but she makes way less money there than she would taking almost literally another job in the state. And home health workers are obviously extremely important to keeping people in their homes. So again, saving money because it's cheaper to do home health than it is to put somebody in a big nursing home that is focused on profitability. But we don't pay. We don't pay people who do essential care, whether they're social workers, home health aides, nurses, whatever, the money that's commensurate with the value they provide. We're not allocating our resources in the kind of way we would allocate it if you wanted to do things like bring down healthcare costs and make people healthier long term.
Well, and two, if you're listening to this and you're like, I don't see myself ending up on Medicaid, or I'm a therapist or a healthcare worker that doesn't take Medicaid, so I don't think this affects me, and these kind of cuts over this long term that we've just passed in this bill, and then the way that and the big beautiful bill, and then the way that is going to de-incentivize states to fund Medicaid and probably result in a lot of kind of secondary chilling effects and cuts. So this doesn't affect me. Yeah, I would make the argument that Medicaid existing and being funded is what puts the heat on private insurers to provide services. This is a pretty broad through line. It doesn't work exactly this way, but one of the ways that you track healthcare policy and benefits and what's going to change is that, Blue Cross Federal follows Medicaid policy loosely, and then all of the state plans will follow over a couple of years what Blue Cross Federal is doing, the direction that it is going. And so even if you're not billing Medicaid, even if you're not on Medicaid as a patient, cutting Medicaid will affect your healthcare and make it worse over the next decade. Can you say a little bit about that relationship and like how that works?
Sure, and that's pretty complicated. I don't want to get super into this. I don't want to get any of the details wrong. But basically, with private insurance, it's a race to the bottom. They want to pay as little as possible, and cover as many people as they can who don't spend money on or whatever. Right? Like that's the trade off. And if you've worked as a provider, you've certainly seen how much effort it takes to get even $1 from an insurance company. And a lot of the time, there's that the price they offer to pay you decreases relative to inflation year over year. And when you pay at the bottom, when you pull out Medicaid, well, it drops. And I don't think it's unreasonable to expect that we'll see insurance companies take advantage of the lower standards and lower minimums to reduce the amount of money relative to the cost of healthcare going up over time. So yeah, it will hurt people. All of a sudden, also you've got this massive base of low-income uninsured people who, again, will get sick, will rack up debt, and will go to the ER at the end of the day. And all of a sudden, your ERs are filled with people who the hospital can't afford to take care of. It is shooting ourselves in the foot. And ultimately, it's in service of giving people who have a lot of money even more money, right? Like all the money that's coming from Medicaid, the $1 trillion cut to Medicaid, is being used to subsidize, along with a lot of deficit spending, giving, I think it was like $4 trillion in tax breaks, which disproportionately fall upon people making 6 figures a year into the millions. It's a direct upward transfer of wealth from working people to the 1%. And people who don't have very much money are the ones that suffer most directly as a result of this that all of us down the road.
And so just to speak to some of the misinformation around, why your representatives are cutting healthcare, because I mean, a lot of the 20% of people on Medicaid in Alabama probably voted indirectly or directly to have it cut, nationally and at a state level. So I mean, to kind of speak to some of the misinformation around this, like you don't necessarily have to share my values as a social worker to understand that a lot of these arguments break down under scrutiny. Because when I hear things about like, well, somehow, trans healthcare is taking away things, these kids are just getting transitioned in kindergarten if they say the wrong thing, or illegal immigrants are somehow getting all of the healthcare and taking it away from you. That's why your policy is not very good. I mean, those arguments are sort of predicated on this idea that there's just so much cheap and available healthcare in America that if you go outside, you'll just trip over healthcare services, that people are just going to go in and just sort of get, kidney dialysis for fun that don't need it or something, and that's why, when I hear a lot of those arguments, it's like, this doesn't work, have you ever tried to receive these services as somebody with Blue Cross? Can you say anything kind of about that sort of misinformation machine and how it functions?
Sure. As you pointed out, like no one's getting recreational healthcare, right? No one's going out there and getting heart surgery for fun. People get healthcare for the most part when they need healthcare. And people who do go to the hospital a lot need healthcare in a different kind of way, right? Maybe they need a social worker to help them figure out what's going on with their life and kind of realign how they spend their time. But yeah, which is not a zero-sum game. In fact, the more money you spend on trying for healthcare, the more providers you can have, and the overall quantity of healthcare provided goes up. Like it is very productive. And so things like flagging, this threat of undocumented or illegal aliens or whatever, that's not true. States, for the most part, don't offer healthcare to undocumented people unless the state chooses to. And I think only like 4 states do that. So it's not happening in Alabama, not happening in Wisconsin. And it's all this false meat that's being thrown around to persuade people who don't know a lot about what's happening in order to get them to vote against the things that shape their own
Well,
lives.
they can see that it's getting worse. I mean, they look at healthcare and they realize that it sucks and they don't like it. But the reasons that it's getting worse that are being sold to them are not real, you know.
It's getting worse because everybody's a middleman and is trying to gouge as much money as possible from people who can pay it, and then offer them either as little but also as expensive care as possible. That's the whole tension there, and there's nobody in the middle setting costs, guaranteeing care, making everybody play by the rules. It's just a total, it's vigilante healthcare out there. Everybody's playing by a set of rules designed to optimize for their own bottom line. And when everybody does that, the bottom line never includes taking care of people who need help. It's a way of siphoning as much money as possible from people who right now don't need a lot of healthcare. But eventually, it all comes for us, right? There's this phrase that they use in disability politics. They do with temporary everybody, which I like, because then again, 1/5 of us, so half of medical costs in the U.S. in a given year come from 5% of the population, and 1/5 of the population is on Medicaid. But that population changes a lot year to year, right? Some years you have a kid. A lot of people have kids that go into the NICU or have complicated pregnancies. People get hit by cars, there's accidents. You could fall at work and break your arm or bust your leg. I met a guy who's a painter who paints houses, and that's like his job. And he tore a ligament in his solar from painting, like at his job. Like these things can happen to everybody, and they do happen to a lot of us. So it's a transient population that moves around year to year, and nobody knows when it's going to come for them. So it's you're investing in, you're protecting yourself against the risk downturn of the future of needing healthcare you can't afford, which will happen to all of us at some point.
Hmm. And it tends, maybe you can help me understand something that I've not quite understood. It tends to be the people that are like learn basic economics that talk about healthcare like it is a market. And it lacks some features of a market, like the ability to choose, the ability to have like multiple options. If I'm having a heart attack in an ambulance, I'm not like, wait a minute, can I, or price visibility. Like a market, you go in and you see these tomatoes cost $5 and these cost $7. So I'm going to choose between, quality or quantity or whatever. If I'm having a heart attack in an ambulance, I'm not like, wait, how much is this going to cost me? What is the procedure that's going to be done? Can I see the rates of the hospitals and the available doctors? and then choose which one to go to. I don't understand how we can talk about healthcare like it's a market. It seems like markets need things like price transparency, multiple options, the ability to choose between them. Like a market. So help me understand that one.
Well, so there is a push for price transparency, and the general government over the past 10 years. And conceptually, I agree with that. We should know how much it costs to get any kind of unit of healthcare. But when hospitals put out, or when providers put out the price transparency lists, one, they do it as little as possible, right? The data files they put out are very messy, very complicated. Experts spend a lot of time trying to disentangle them. One can't figure out how much stuff costs. And two, there's so many factors shaping how you get healthcare, where you get healthcare, that you can't choose. And we've done studies. There have been studies of what happens when there is full price transparency. People don't, quote unquote, shop around because they can't, because you've got a doctor that you see, and you kind of delegate the choice of what care you get and where you get it to that doctor. So that's like, if you've got a chronic condition that requires 5 different things, like, do you really want to, let's say you got something, let's say you got cancer. Do you really want to shop around to 5 different hospitals that don't talk to each other to figure out where you get every particular unit of cancer care? Of course not. That's ridiculous. One, that's way more than the average person can do navigating all this data. And two, like, if you have cancer, you're busy dealing with fighting cancer. The sicker you are, the less capacity you have to navigate all this paperwork and do all the shopping around. So we see that people don't shop around.
Where they drop you. If you tried to get this cancer treatment here and this one here and actually price that stuff out, if you could figure out what it cost, you had the wherewithal, you had the transportation ability. I mean, those providers will not let you treat in that way. I mean, they will drop you as a patient unless you're kind of getting these services as a bundle, as a part of complex care, because of the way that medicine works, that it needs to be integrated. The system needs to know, what treatments you've had and have all that kind of documented.
This whole idea that you can just shop for care or do price transparency and figure it out ultimately creates scenarios like this, right? You've got a kid, the kid is really sick, there's 2 drugs you can give the kid. One will bankrupt you, but the kid will get better. The second one, you can kind of afford, you can swallow it, but the kid might not get the best healthcare they can. They might not recover. So how do you choose, right? How do you force a doctor to choose what they prescribe you? You create these really perverse incentives. Ultimately, you're being asked to choose between your money and your life, like the pirates used to say. And there is a lot of things like piracy happening, and it feels like you're getting robbed by a pirate. But you can't ask somebody to make that decision. That's not a reasonable decision to make. To have to decide.
That isn't a market. Choosing whether or not you die lacks some of the essential features of a market also.
I can choose not to buy tomatoes this week. I can choose that I'm not going to make red sauce for my wife. I can go ahead and make a salad or whatever instead. Now, can I really choose, whether I want my kid to live or die? No, I'm a captive audience. And I mean, on top of that, you shouldn't have to worry about whether you go bankrupt from your kid, being sick or whatever. That's the situation we're forcing upon a lot of people, and you don't have freedom of choice. You can't have freedom of choice in healthcare unless one of the choices available is to die, which I don't think really counts as a market decision. The structural forces which shape healthcare are well beyond the capacity of an individual consumer to navigate. That's why we have these systems in place to help make stuff work for people. They're not doing their job. They're inadequate to getting the job done. One, because they are too small, perversely, to really get the cost and optimization process that they need, or to integrate all the healthcare that you need to provide. And two, because they don't really want to, because they make a ton of money at the end of the year. United Healthcare, I think they pay in something like $4 billion. I don't know the actual number at hand, but they're making more money than God every single year, hand over fist. And still, at the end of the day, you're being denied the care you need when you need it, or you're losing your insurance. Like, everybody wins except for the patient in the healthcare system.
So, just to kind of close out, could you tell us some of the maybe stories you've collected about the kind of absurdities and redundancies, and when you introduce private equity into these systems and the perverse incentive structures? Because I mean, there is kind of some bleakly comic stuff. One of my members of my family works, approving SSDI in one of the offices, and one of the things that he still has to do, to prove disability is to prove that somebody couldn't work as a magnetic tape winder or a typewriter repairman. those are two skills that, you have to rule out that the person is not able to do because there's such a burgeoning industry of typewriter repair where they may be able to get
Yes.
employment if they weren't on disability. There's some wild stuff in there. Do you have any of those? Can you regale us?
I got one example. I got a buddy in New Jersey named Steve, and Steve has muscular dystrophy, right? Basically, his body's eating itself. He weighs something like 90 pounds. He lives in a wheelchair. His life expectancy at birth was 18 years. He's currently 32 or 34. So Steve's chucking along. Steve's a teacher. He's a stand-up comedian. He's been on TV as an actor. But Steve needs home health, right? Steve needs a pilot wheelchair. And Steve needs somebody to come over every day, and help him feed himself, bathe himself, go to the bathroom, stuff like that. It's just the way his life is. It's fine. Because of these services, Steve can live a normal, dignified life and do the work he wants to do. Everybody benefits. But every single month, Blue Cross sends a nurse to his house to check and see if he's still disabled and still qualified for care. It's like,
Which I imagine there's some expense, got to pay her salary or his salary.
that's good. And also the process of doing all the paperwork to check and double check and triple check is expensive. It costs time, it costs money. But yeah, like Steve is still disabled. He hasn't suddenly cured all his muscular dystrophy and then gained the ability to walk and use his hands and stuff.
It'd be pretty miraculous if, the nurse came and all of a sudden a degenerative condition had gone away. I mean, they're spending a lot of money to assess every month if a miracle has taken place.
Well, it's not like he's getting better care because of it, right? It still takes Blue Cross half a year to approve a fix to his wheelchair if it breaks. It's not like they're, doing it out of concern or investment in his long-term care. It's just a way of cutting care whenever possible. Because now Steve has to set up that appointment, they have to sync up in time. And sure, Steve's lucky, but he can do these things. He's got help. But for some of the folks out there that can't, or there's an accident, or they miss their phone, or they can't, or their phone breaks, or they can't pay their phone bill, or they're moving, or whatever. And so for whatever reason, they miss the appointment, and all of a sudden, bam, they're not getting the care they need for that month. This happens all the time across the country. And it's a very silly way, a very stupid way, I think, of arranging a healthcare system.
Well, one of the things that I think is the way that you get away with kind of crimes in the American political system is that you find something that's pretty bipartisan, that if you just ask 80% of the country on the street, 90% of the country, do you agree with this? They would be like, yeah, of course. If you do that, you're going to get this result. I want that result. So why would we do this thing? But then you find some way to split that constituency by picking something that's aesthetic or sort of a cultural value, religious value, or, some part of spectacle and aesthetics to make sure that these people can't have political capital because they won't agree. They won't vote for the same person. And, something like price transparency, like we had a price transparency in healthcare bill that sailed through Alabama and everybody was broadly in support of it. And they were saying no more surprise billing. So there's all this paperwork on me now as a therapist to tell the patient all these things that are already kind of self-evident, and they would know. Like if you're on a sliding scale with me, we have a sliding scale at my practice. So if you make under $30,000 a year, then I'm only $80 to see for complex trauma therapy. We can generally get complex trauma treated with brain-based medicine pretty quickly. Or if you make $40,000 a year, I'm $85 or $90 to see. I don't have my sliding scale memorized, but so the price transparency bill was like, no surprise billing. You got to tell these people every 3 months exactly how much they're going to pay. Well, it's pretty simple to understand a sliding scale or a private pay rate because you know what the price is for every hour that you come see me. It's going to be this. But that bill doesn't apply to insurance. Insurance doesn't have to do that. It's only private pay services on a sliding scale. Like the insurance industry made sure that you don't have price transparency, that this law doesn't apply to them in Alabama. And so a lot of the time it's the people that are getting hit with a surprise with me because they thought that they had mental health coverage, but Blue Cross said, oh, actually you can't have rape counseling because you didn't get blood work this year and have a PCP visit for primary care. So your prior authorization can't be approved. Something like that. What are like broadly bipartisan, just obvious things that most people would agree with that we could do tomorrow if anyone wanted to?
I'll need to think through to give you some more specific answers. But ultimately, having a central authority that can help regulate and bring down the inflationary costs and make it more right now, you've got this clean war, I said, between all the paperwork people at the hospital and all the paperwork people at the insurance company. And these positions, these jobs, just you get more and more and more every year as both sides find ways to screw the other. You can simplify that. You can say, listen, Medicare pays $100 for your shots, for your shots. Everybody's going to operate as a function of that, right? And you agree, I'm going to pay 110% of Medicare or whatever. Well, there are things you can do to help like streamline and regulate the way that pricing works. Now, you actually can tell what something's going to cost, but right now you can't do. There are things like that I think are popular. When you talk about things like Medicare for all, the overall majority of people, when they have it extended to them, are in favor of things like Medicare for all. It's not necessarily a universal bipartisan issue, but it's got a lot more support across the spectrum than people anticipate. There's just a lot of stuff there, like everyone knows they're being screwed, right? That's the thing I found whenever I talk to anybody, any part of the country, everybody knows they're being screwed in some way by the healthcare structure, either them or somebody that they love or somebody that they're close to. Nobody is far. Nobody's more than 1 or 2 degrees removed from somebody who's been really screwed over by this whole arrangement. And there are big things and there are small things you can do to hack away at it. Problem is, it's going to cost somebody their profit, so we don't do it. But yeah, there's lots of kinds of regulations that are proposed in big and small ways. What I'm working on right now in Wisconsin is if a hospital is nonprofit, if it gets all kinds of tax breaks, it's supposed to, in theory, spend money that it would otherwise pay in taxes on providing community care. We're going out to the neighborhoods and rural areas and small areas that are underserved and helping get them health care, providing charity care for really low-income people. And they don't, and there's no regulation whatsoever. So we've got hospitals that receive running to $30 million more in tax breaks than they spend in community benefits. That's a clear perversion of this whole agreement that we have for why hospitals are nonprofit. And they don't do it. They just don't do it. And so it's regulations like that, which force people to play by the rules we've already established. I think we'll see more and more momentum towards that over the next few years.
I have kind of a theory that has to do with like the graphic user interface of things. That if something is like an optional service that you don't really need, they make it incredibly easy to do. Whereas if something's a mandatory service that everyone has to do, then they're able to sort of harass you through the user interface. Like at a gas pump, gas pumps like they don't work great. You have to put the thing in the right order and put the hose back. It can show you ads. It can blare advertise because you have to get gas. You're not going to drive away. But you can easily, doing insurance claims or insurance reimbursement or even understanding your benefits as somebody who pays for them as a patient and somebody in network with insurance, like that stuff is the most complicated, hard thing in the world to use. And, there's no kind of universal app that just says like, hey, here are the doctors that cover you around here. Here's how much your benefits cover. Hey, your GPS says that it looks like you're at a clinic that's not covered. Do you want to file a prior authorization if you're doing a visit here? Here's places in your zip code. I mean, while it's incredibly easy to say, well, I can't afford this $19.99 pizza from Pizza Hut, but this little app is going to go ahead and run my credit and let me finance that over 6 months. I mean, I can finance a pizza easier than I can understand my healthcare benefits.
Ultimately, people that are providing the hospital, people that are paying for it, don't know how much stuff is going to cost until it goes through the entire machine. Asking an insurance company how much does it cost to get you, hand amputated or whatever, impossible to know. There's so much Byzantine layers of paperwork and processing that you can't even predict these prices ahead of time. It's just the whole model is too complicated to lay out as simply as a menu. And so you simplify
design. I mean, how much of this stuff do you think is just stupidity, and how much of the stupidity of bureaucracy, and how much of it do you think is intentional?
I think it's a series of accidents that kind of roll downhill, like a stone out of a moss or whatever, right? Insurers want to find a way to pay as little as possible. Hospitals want to find a way to charge as much as possible. And so they've got the one guy makes a move and the other guy puts up a counter move and they go back and forth building this massive structure around it. And it's a way to shirk responsibility and try to push more on the other guy, and patients get caught in the middle.
Yeah. Well, that was wonderful, and you really have a lot of experience. I appreciate your time there. Is there anything that we don't get to, or you think is kind of a good cap to that?
It's even fun to talk to you. This is very fun.
And is there anything that we can link to or help you promote? Some of your articles, or you work on anything now? What would you like people to be able to click on in the show notes if they want to find out more about what you do?
Sure. I've got a newsletter that I write very infrequently about healthcare issues. Right now I'm focusing on stuff I'm writing. I'm working on some bills in Wisconsin that I'm writing up there. I picked a really dumb name for it, but it's buttondown.com/error. I'll grab the username just so I figure out what I want to do with it. You can link to that if you wanted to.
Oh, great. Well, thank you so much. I really appreciate your time here, and it's been wonderful speaking with you. Tim Faust, thank you so much for joining us. And there'll be more that you can click on below if you want to find out anything else about, what Tim does or how these things work.
Thanks, man. Have a good one.